Hello, everybody. So I'm going to be only 10 minutes, and I have my slides numbered, which gives you your light at the end of the tunnel. So you can. I think PowerPoint should move to doing this as a function, like a thing that you have, like a page number, but it should be page of this, because you can become desperate in the middle of a presentation, and you want to know how much longer you have to go. So I'm a family physician in Cleveland, Ohio. I did 2 projects this year. One of them was thanks to the foundation grant. The other one was in part because I had a year as an academic fellow basically to do what I wanted. It was through a Medicaid workforce grant called MedTap, which allowed me to do primary care innovation in my clinic and not have any of the requirements for patient volume that you might otherwise have had. So the 2 projects, the one that was supported by the foundation was health coaching. It was inspired by the work of Tom Bodenheimer at UCSF, who basically has written about how with health coaches in primary care offices, a lot of the chronic disease management can be delegated to medical assistants, community health workers, and the outcomes can be impressive for both diabetes and for hypertension. The other inspiration for health coaching was Erick Coleman's care transitions intervention out of Colorado, basically showing that although he was using advanced practice nurses, he only did that for a legal reason, and he actually created an intervention that could have been done by non-licensed people, where you basically are prompting people to ask questions about their health care during a hospital admission, and he showed a 30% decrease in readmissions for that group, not by giving them any information, just cueing them into things that they should ask about, like their medications, like red flags for an illness, like when their follow-up appointments are going to be. So both of these were using non-licensed or at least non-physician workforce to do both chronic disease management and care transitions with positive outcomes. The super utilizer program was was the other project I was working on, and that was inspired by an article in the New Yorker by Atul Gawande about Jeff Brenner in Camden, essentially looking at the 1% of patients that consume over 23% of healthcare costs. And he's a family doctor, and I was inspired by the idea of, in both cases, both projects were born of this feeling that when you have a really complicated patient in clinic, your feeling should not be overwhelmed and, oh my goodness, this should be your joy. This should be exactly why you went into medicine. It shouldn't be, I can't use my mind and my creativity and my emotional worth in this encounter because of the 15-minute visit. Rather, this is where I should be spending most of my time as a physician. So it was that feeling that I wasn't perhaps giving the kind of care that I thought I could in residency that led to these 2 projects in this fellowship. Both projects were informed by both the Lean Startup, which is a way of innovating, and the Institute for Healthcare Improvement's model of improvement. Both of them talk about small iterative changes, PDSAs or build, measure, learn cycles, testing things out before you get it perfectly, and doing things with a very small budget. So this first project was, I'm going to give you just 5 slides. This one and the last one are the front and the back of a story about one of my patients. So her name was A.H. She was a super utilizer. This was about the spring of this year. So I had been given the hospital's top 28 most frequently admitted patients to see if primary care could help them. And she's a 23-year-old with postpartum cardiomyopathy. She had over 12 admissions for heart failure. So postpartum cardiomyopathy is a heart condition where your heart doesn't work after you have a pregnancy and deliver a baby. The mechanism of how it happens is very hard to know, and its prognosis is also very hard to guess. So she had cost the hospital system over $500,000, and I had been directing her care the same way that I thought I should do care in residency. Like, you just figure out people, and you just figure out, make your problem list, you assess everything with all your brain power, and you kind of just give them the information, and then that will be it. And I thought if I just did this kind of directing care that I had done in residency, but now I have to hours to do it, and I can go to your home to do it, that would be really effective. So she fired me. So she didn't want me directing her care, and I thought it was brilliant. I thought, she's overwhelmed by her illness. I just need to break it up into pieces so that she's not, because what she would say is, I can't take care of my children. I can't both take care of my children and my illness. So she was choosing to take care of her children. And I was getting into like the personality disorder. Maybe she's blames her children for her postpartum cardiomyopathy, and now she's making choices that are compromising her health, which are not necessary. So I thought I had her figured out, and I just needed to break down her health problems into small pieces for her to digest, and she fired me. So I'm sitting outside of her house in the driveway after she fired me, because she still wanted to work with my medical assistant, she was actually a student, but she was so good at listening to this woman, and she was similar in age. And I was like sitting in the car and thinking, okay, this is great, because she'll keep the door open for me, and I'm where the care is, right? So I'll have to kind of be humble and sit in the car while they do touchy-feely, warm stuff. And the health care, as I know it, will be on hold until I can get back in there and still keep and direct her some more. And I wasn't completely arrogant. I had numbers to prove that I was having an impact on these people's care. So we did this very small pilot where we took half of the patients who were in this high group and half who were not in the high group. And I was dramatically impacting ED utilization, inpatient stays, and the costs of care. So here I am thinking I'm the man. So just to describe now this iterative learning. With this health coach program, we started with diabetics. We were doing, so my idea was that people don't get enough time to understand their chronic illness. So they get the 15-minute visit with a doctor about diabetes, and then it's like, I don't care if you have time, if you don't understand what I just said, see you in 3 months. And here's all your medication you have to start, and here are all the things you have to do for self-management, and bye. And so I thought we need more time to do teaching. So I trained these coaches to teach, and they would have like an hour. But the clinic did not want people in the room for an hour because of volume. So we moved to the inpatient setting where we had more time. And then I realized everybody is teaching these patients. They are in the hospital all the time. So the diabetic educator is teaching them, the nurses are teaching them, their doctors are teaching them, so they don't really need more teaching, and they really weren't looking forward to somebody without a license who I had trained in a 2-day course to teach them about diabetes. But they really did, and it was sort of like noticing what the times in between when we were doing stuff to them. They actually liked when we tried to stop teaching. And when we just sort of went in there without an agenda and we started to listen. And we started to want to hear their stories. And so it was kind of fun. You'd be in like a floor full of hospitalized patients, and they all were like these exciting like chocolates in a box that you could open up. It was like, it transformed it when you didn't have a work to do, an agenda to set, but you could just go in there and enjoy somebody who really, it seemed really wanted to air some thoughts and have someone listen to them. It was fun for everybody. But, so if that was motivational interviewing's framework, that was the engagement phase. What I started to realize with the program is that these coaches have this in with people that I am not seeing. And that in, I have shifted my thinking then that's an in for more information and teaching. I think that's an in now for eliciting the person's motivations, for focusing on behaviors that they want to change. And those behaviors, I think, are habits. So if you're finding out, a coach can spend a lot of time with you finding out what medications you're taking and how you take them. And that can be the time that nobody else in healthcare has to spend, but it also can be the most important thing about their healthcare if something's wrong. So the superutilizer intervention was running in parallel. Again, I was describing how I was doing things. I was essentially thought I was the solution for their care. And what I realized was that it was not so much about understanding their disease better, it was understanding them better. So there was something probably very basic in the highest utilizer in a hospital system that was being missed. Like they couldn't read the type of insulin they were taking. They were giving themselves the wrong type of insulin because of illiteracy. Or they had no organization for medications. Or so there were things that you can't uncover unless you're in the community and you're spending time with them, and unless they trust you, because everybody has accused them of doing things wrong, so they're not going to be ready to tell you, to let you come alongside and have you understand how their life looks until you've built that trust, I found. And the other realization we had was that we look for the highest utilizers in the hospital system, and that will bias you towards emergency room, because people who get admitted, who have a lot of unplanned events, will be ED utilizers. That will also give you a high preponderance of mental illness and addiction, which we've shifted away from because of the challenges of engaging people who are not in necessarily the action phase of change for addiction, because they're not coming to the hospital for their addiction, they're coming for a medical illness. So we saw quickly that we needed to shift to the inpatient setting to engage people with ambulatory sensitive conditions and chronic illness. And so we've merged these two programs for this program that we have now, which is essentially health coaches going out to the community with superutilizers, using motivational interviewing to focus on habits and how they can evoke intrinsic motivation to make habit changes. So now, last week I was outside in the driveway now, and I'm doing it because that's the way the care is delivered best. Not because I'm not allowed in. I'm doing it because I realize a superutilizer doesn't need more health care. They don't need me in that room. I'm sitting outside in my van because the health coach who I've sent in there is going to listen to them, understand them, evoke their own motivations for change, and help them plan and achieve really sustaining life changes. And so the program has 85 volunteers trained, mostly undergraduates. They're patient-provider orientation, so they're more patient-centered as a result. This was a significant change. This was not a significant change, but there was some increase in self-efficacy. We had a group that had a baseline survey and did not get the coaching intervention compared to one that did. They did have an increase in activation, which had a p-value of 0.002. That's sexy. Patient activation measure is very, like, the hot thing. And a couple of them wanted to go into family medicine after the program. Yay. Who didn't before, as indicated by that red line. So in my last minute, I'm sorry, it took 15. So my lessons learned were having the space to innovate. It's not just like, oh yeah, let's stop fee-for-service and then do primary care. It's like we are ingrained in doing a model that in one way, and to have grants like this where you say, here's some money to think out your ideas, or to have a fellowship that says, I'm going to protect you from the financial reimbursement model that you're currently in, just to be thinking about how great care could be, is really important. I think we should just insist on it. Efficiency doesn't trump effectiveness, and management doesn't trump leadership. So if you look at a problem list for one of my patients with diabetes, before I did this, it had 12 problems. I had moved him nowhere on the spectrum of improvement on them, but I felt really great that I had done 12 things in one visit. When I spent an hour with him he's illiterate, pronouncing each of his medications so he knew which ones to take. I had nothing to document. I had no billable code, and I had the most impact on his health of any of the other times I had been with him. And the tail doesn't wag the dog. So I had a call from a nurse who said, this patient, her weight, her heart failure has gone up, her weight went up 6 pounds. And I'm thinking I should get on the phone, call her, and tell her to increase her diuretic. And that's really going to be good if my outcome measure is readmissions, okay? Because I can save her from the hospital admission. If what really matters is how activated this person is she going to take charge of her own health in the future, or will she need someone to rescue her? Then I will wait for that call, risking my end outcome measure, because if you see your value really as as the person's activation and not the outcome, you are. So in other words, you had to say it's more important to measure the good stuff than to do stuff to affect the measures that you set up in advance. All right. Thank you.